We'd now like to start with our session, and this is deep venous disease. I'd like to invite our chairperson, Dr. Edwin Stephen, and Dr. Tarun Grover to please join us on the stage. May we have you on the stage, please. I'd like to invite our panelists to join us, Dr. Bhakta Vachalam, Dr. Rajarajan V, Dr. Balakumar S. Do we have them with us? Yes. I'd also like to invite Dr. S.K. Tiwari and Dr. Ilya Kumar to please join us on the stage. I'd like to request each of the speakers for stepping up to the stage. Your time limit is 8 minutes only. We'd really appreciate if you can stop at 7 minutes, 30 seconds. And those of you who are asking questions are requested to come closer to the mic, be louder and be clearer. And the session's about to begin. I'd like to hand over the session to our chairpersons. Over to Dr. Edwin and Dr. Tarun.
Thank you. Thank you for that. For a minute, you had my attention when you said you can go and speak to the Kanchipuram sari people and they will help you. And then she said with information. I thought we'd get some saris for free. Thank you. So we'll get on to the session without much ado. And we have Dr. Robbie, who is going to take us through the nuances and the importance of IVUS in deep venous system. We all know that this is coming on, and thanks to inputs from several of us sitting in the hall and those joining us virtually, this is quite an important topic. So over to you, Robbie.
Thank you. So just saying it's good to be back here in Mahabalipuram, so I'll get going with this. So we all know what the limitations of venography in looking at the deep venous. Essentially, you're looking at a low pressure system. There's a poor correlation with compression because the pressure differentials are really very low. So you always look for other clues. Is there some pancaking? Is there some flattening of the vein? Are there collaterals? Or we started doing what we described a long time ago, looking at trial ballooning to see if there is a narrowing. Now, none of those are particularly good. So that is where the role of IVUS first came in. So IVUS takes its origin in the coronary world, where it was very popular. It was really brought into the peripheral venous system by good old Dr. Raju, who we've all got to thank for unveiling the deep world to us. And after many years of the work that he did, they'd come up with this trial, which is the venography versus intravascular ultrasound for diagnosing and treating iliofemoral vein obstruction, which is the video trial. I'm just going to quickly go through this. So that's just the data on the basis of which we are kind of defining what should be practiced today. So they did 100 patients across 14 centers, looking at advanced disease, so the indications for doing it were right. They compared multiplanar venography, looking at the common, the external iliac, and the common femoral vein in 3 directions, in 3 planes. And they did an IVUS for all patients, and they considered more than 50% stenosis as significant, which is fair. What they found was that multiplanar venography underestimates diameter reduction significantly. If you use diameter measurements alone, using venography, you will miss a lot of lesions. When you start doing IVUS, and you use this definition of 50%, you will pick up an additional 1/3 of patients whom you would have missed on venography. And most of us, we actually practice venography maybe in multiple planes with a trial ballooning to try and identify these more subtle lesions. So what's been the impact of doing an IVUS on a patient where you suspect deep venous pathology? So the distribution of treatment plan changes. If you look at the 57 patients who underwent treatment, 35 went from no treatment to getting a stent. So literally 1/3 of your patients ended up getting a procedure where they were not. In 13, the number of devices you required extended because you were able to identify the extent of disease as being more than what was apparent just on a venography. And in some, it changed the plan from treatment to something else. And in 3, it actually changed the plan from treatment to no treatment, which is actually interesting that you were able to define on IVUS the problem is something else and putting in a stent is not going to solve it. So what video showed was that IVUS is more sensitive for assessing treatable iliofemoral vein stenosis compared to venography, and it leads to revised treatment plans, which is fair enough. Now, When I started looking at IVUS first, it all seemed like one black blur, and I really did not understand very much of what was going on. So I'm showing you a couple of videos which hopefully have come from our experience, and hopefully is a bit easier to understand. So this is just an introduction of what IVUS looks like. So you see the middle bit over there where the catheter is kind of, you can see the catheter in there. Up there, somewhere at the top or the bottom, anywhere, it can be the aorta. Now, remember, the IVUS catheter does not always sit at 12 o'clock. So the aorta can be at 12, 6, 4, 3, anywhere in between, because the catheter itself can rotate. The blue bit there, the big black one in the middle, is, of course, your IVC. And as you come down, you begin to see the bifurcation of the aorta splitting into the right and the left common iliac arteries. And you can keep identifying this. And remember, the artery might swing around as your IVUS catheter rotates. And you can begin to see compression of the left common iliac vein between the vertebral body behind and the iliac artery above. And this is not something which you're very well able to appreciate on a normal venogram. And you can keep tracking this. So you see the left common iliac artery where it splits again into the hypogastric and the external. This is another site where you get compression of the iliac vein. This is another site which you're able to identify on IVUS, which is very easy to miss otherwise. So when you do an IVUS, you really want to start from the very top, pull back all the way down, and I always combine this with an ongoing fluoroscopy so that I know where the catheter tip is. So I've got a fluoroscopic landmark and what I see on the IVUS for me to figure out where I am. So this is one of our patients where we did a venogram, and it looks like maybe there is something at the right common iliac vein. When you do the IVUS, you see the degree of compression she has over there of her left common iliac vein, which confirms the fact that there is a problem which looked very equivocal. So by doing IVUS here, we were happy that there is a problem. You do your diameter measurements, and this gives you good accurate diameters as to what is the size of the normal common iliac vein where you want to go in. And it does an area calculation, and it actually shows you area reductions as well if you want to see them. So when you look at area reduction, that is much more specific for knowing how significant the degree of hemodynamic obstruction is. Once you have that, we stuck in a stent. The venogram looks beautiful. And if you look at the IVUS, so that's coming into the IVC, you're beginning to see the top of the stent struts coming down, and the stent is nicely expanded. The vein walls are touching it all around. So this is an appropriately sized stent that has treated the entire lesion. So we'll be able to size the stent correctly when you do that. This other case was a chap with 2 chronic venous leg ulcers, both legs. He's had them for years. Superficial scans did not show much. And when we do the venogram here, he repeatedly has significant reflux down both iliac veins. The blood's just not going into the IVC. And when we do an IVC venogram, again, there is reflux coming all the way down into both the iliac veins. So is he a classic refluxing pathology? And honestly, we used to do a lot of deep vein valve reconstructions, but since the onset of deep vein occlusion that you've worked it out, you realize that the majority of them have an occlusive problem somewhere. It's this failure to identify because of which we ended treating that. We did another venogram going higher up, and you see what looks like a classic suprarenal suprahepatic IVC narrowing. Now, is this just part of the diaphragmatic pinching, or is this real? So when you do the IVUS here and you're coming down from the heart, you see that area of narrowing that just went past? That was a really, really tight, narrowed segment which was scarred. Can we play this video again, please? Unfortunately, I don't have the controls here. Yeah, thank you. So coming now, you see that bit where it just squinches down? That helps you identify what is happening there. And this is when we come down the right leg. This is from the IVC, that narrowing within the, where it joins the heart. And when you inflate the balloon, we actually don't see that much of a waste. And this is the problem in the venous system. You can have a subtle obstruction which is causing significant hemodynamic compromise. This is not like the arterial system where a tight stenosis is always seen. So we go ahead, post-IVUS, there is better clearance. It still does not look great. I'm personally not very happy to put in a stent over there which might stick into the right atrium. So we elected to just plasty that. Did a venogram on both sides, which again now shows that there is forward flow going through, but it still looks flattened. We decided to stent both iliac veins. So this is the post-stent. So you're seeing the stent coming up shortly inside. That's the stent. That's the opposite side stent that we're seeing over there as we come down. The ipsilateral stent, again, nicely within the system over there. And similarly on the other side. So IVUS here showed us that we have actually managed to treat both of those iliac vein segments adequately. This is at the top end of the IVC where we are coming down. Looks clean, keeps looking clean, and we don't see that narrowing we saw before, which made us much more happy about not putting in a stent into an area where we did not really want to put in a stent. So IVUS changed what we would have done here. We've used IVUS for following up patients who've had stents, who've not got anything new, but we just want to make sure they're not missing anything. And you see this again, that your stent is widely patent. This is somebody whom we've done an endovenectomy and a stent for. Venograms look good, but again, these are patients who are precious. You don't want things going wrong. You do an IVUS, the stent is nicely in place. There is a lot of scarring around it, but the stent is open, not compressed. There's no luminal loss. And lower down, we come into the endovenectomized segment, which also looks fine. So IVUS definitely adds to the diagnostic and therapeutic decision-making process for deep venous disease. I personally don't think it is that helpful in post-thrombotic syndrome, other than for the sizing. It is especially useful for the compressive syndromes like the classic May-Thurner. Thank you for that.
Thank you, Roby. Thank you. We'll take questions in the end. Thank you. I think we have Dr. Arvind Das Lee, who I was hoping to meet in person here, but he has probably sent in his recording on, again, another topic that we don't see much of, but is of interest, Paget-Schroeder syndrome.
Greetings, friends. I'm here to discuss some of the issues with the management of Paget-Schroeder syndrome, and I'm grateful to the organizers for providing me with this opportunity. We all know that it is a rare condition. It is seen predominantly in men in their 20s and 30s who are otherwise healthy and often athletic, muscular build. It is more common on the right side of the for the pathogenesis, one has to look at the anatomy of the thoracic inlet again. The subclavian vein traverses through a narrow space between the first rib and the medial end of the clavicle. In this space, there is also potential compression from the subclavius muscle and the costoclavicular ligament. Repetitive trauma over the vein from all these structures can lead to perivenous scarring, which ultimately leads to sudden acute thrombosis, which presents as epoch thrombosis. The diagnosis is often obvious on history and examination. Duplex imaging can be confirmatory, sometimes limited by body habitus and the presence of the clavicle. When in doubt, we perform a CT venogram. MR venography and catheter venography are also other options. Hematological testing for thrombophilia is not generally warranted. However, there's some data to suggest that there's a high prevalence of thrombophilia in this cohort. We did have a patient not long ago who ended up being a triple positive antiphospholipid antibody syndrome. He had extensive clot burden, including the superficial veins in the arm. So anybody with that kind of presentation, along with some unusual features, may warrant a thrombophilia screen. Moving on to the management, which is of course the main purpose of this presentation. So what happens when we just anticoagulate these patients, which is in fact what the ACCP recommends for all upper extremity DVT. Data suggests that there's a 20 to 30% risk of severe post-thrombotic syndrome with just anticoagulation. We have data from the late 90s, which seems to suggest that with anticoagulation alone, you can expect total symptom resolution in anywhere between 17 to 40% of people. So the vast majority will be left symptomatic with coagulation. Looking at lysis, it can of course be of any form, CDT, pharmacomechanical with devices like the angiojet, JEDI, even the ECOS catheter, any form of lysis would work, and what was available can be used. And provided that the indications have been appropriately selected, one can expect that with lysis you should have good thrombus resolution. And usually on venography after lysis, one would find significant venous scarring in the just below the medial end of the clavicle. However tempting it may be, it is not the time to be performing any endovascular treatment at this stage. It universally leads to poor outcomes. Because of this, we look at decompression of the underlying bony fossa within the thoracic inlet, and this centers, of course, on removal of the first rib. A systematic review in the Annals of Vascular Surgery in 2015 showed up to 95% relief of symptoms with first rib resection as compared to 54% with lysis alone. Another systematic review published quite recently in the JVS 2021 again gave very good results with first rib resection of symptom relief up to 98% as compared to 70% for lysis. So to summarize the treatment outcomes, anticoagulation alone, one can expect about 40% complete resolution of symptoms. With adding lysis, you can expect anywhere between 55 to 70%. And when we have decompression using the first rib resection techniques, then we can get over 95% symptom relief. So if it is worth removing the rib, when should we do it? There are a few things to consider in response to that question. Firstly, data would show that in 1 in 3 patients, there will be a risk of rethrombosis of the lysed vein if the time between lysis and decompression is extended beyond 6 weeks. One of the fears with performing rib resection early after lysis and having the patients marinate in heparin for many days is the risk of bleeding and complications. Data would suggest that in most first rib resection series, the risk of hemothorax and significant nerve injury runs at about 1 to 2%. A recent randomized, not a randomized trial, a systematic review shows that by doing the first rib resection within 2 weeks of lysis, the bleeding rates runs at about 7% compared to when it is done after 2 weeks. However, there is a compromise in terms of the preoperative recurrent thrombosis. Subgroup analysis of this series showed that in 2/3 of the patients in the early group who had bleeding complications, most of them were in the group that had their ribs resected within 24 hours after lysis. So that would suggest that the best window is anywhere between 1 to 2 days after lysis to 2 weeks from lysis time. What's the best approach to removing the first rib? Transaxillary is familiar to a lot of us. What one must remember is that the areas of bony compression is actually in the anterior end of the first rib and also over the medial end of the clavicle and its attachments. And even with the transaxillary approach, it is important to extend the resection to include this part. A supraclavicular approach, which is again what we would use for arteriothoracic outlet, would be somewhat compromised in terms of removing this part of the first rib simply because the vein would get in the way. We find the infraclavicular approach is the best approach for venous thoracic outlet syndrome. This is a relatively straightforward approach, starting below the clavicle on the medial end and removing the subclavius muscle and the costoclavicular attachment before taking care of the rib. We often don't end up removing the posterior end of the rib, but it doesn't appear that that is going to be of any great significance. Should we be stenting the vein or considering things like open venoplasty? In my limited experience, I would say no. Patients tend to do quite well once they have had lysis and first rib resection, regardless of how ragged the vein looks after venography and angioplasty. There are, however, some series which have looked at stenting in this space, and patency rates tend to range between sort of 55% for primary patency and up to 100% secondary patency. I do not think that it would be something to use on an every case basis, but something to consider if there is significant residual stenosis or symptoms in the longer term follow-up. So to summarize, anticoagulation alone may not offer good symptom resolution in majority of cases. Lysis and first rib decompression offer better long-term outcomes with excellent resolution of symptoms. The infraclavicular approach is eminently suitable for decompression of the thoracic inlet. Stenting is not something that is routinely recommended and may be reserved for persistent symptoms or high-grade stenosis on follow-up. Thanks for your patient listening, and I'm happy to take some questions.
Thank you, and now we move on to the next speaker. He happens to be Dr. Adarsh Kabra. He will be joining us virtually from Jaipur, and he's going to speak on pelvic venous disorders.
Good morning, everyone. Well, to define pelvic venous disorders, it's the spectrum of symptoms and signs that arise from the veins of the pelvis, that is the gonadal veins, the internal iliac veins, and their tributaries, and the venous plexuses of the pelvis, and their primary drainage pathways, which involves the left renal vein, the iliac veins, and the pelvic escape points. Now, before we head down to what exactly pelvic venous reflux is all about, we need to first find out what the anatomy is like. Now, what we need to understand is that a single internal iliac vein is seen in approximately 73% of the patient population. 27% have two separate internal iliac vein trunks, which can be separated by nearly 2 centimeters. More common in females, nearly 35% compared to males. And if there is a duplicated trunk on one side, there is a 50% possibility of the duplicated trunk on the opposite side also. Very rarely the internal iliac vein can drain directly into the common iliac vein confluence. I have myself seen 4 such cases, and it is an important variation to remember. As far as the valves are concerned, the common iliac vein had a valve in only 1%. The external iliac vein had valves in 26%, which was a parietal bicuspid valve, usually located 2 centimeters from the ostia. The right external iliac vein system had 3 times more valves compared to the left, and the internal iliac vein had developed either ostial or parietal valves in only 10% of the patient population studied. Clinical history has a lot of meaning in this situation because there is a significant overlap of symptoms between the venous and non-venous causes. Venous origin renal symptoms can relate to micro or macrohematuria. It can be also left flank or abdominal pain, which can be worsened by standing, sitting, or walking. There can be pelvic symptoms, which can be dull unilateral or bilateral pain with occasional sharp flares. There can be pain at the buttock or perineal region in the standing or sitting position. Prolonged postcoital pain is very frequently seen in this situation. Now, a combination of postcoital ache and tenderness over the ovarian point was noted to be 94% sensitive and 77% specific for distinguishing a venous origin cause from other causes of chronic pelvic pain by Baer et al. Way back in 1988. Now, of course, symptoms can be localized to the external genitalia or the lower extremities also, and they arise from either reflux through the recognized escape points in the pelvic floor or from iliocaval venous obstruction. In men, it's often seen as testicular discomfort or infertility. Very, very rarely does it cause features of chronic venous insufficiency in the lower limbs. Rarely, it can be associated with sciatic or tibial nerve symptoms. Symptoms associated with sciatic nerve varices include pain radiating from the buttock to the lateral aspect of the leg, which is often worsened by sitting. Now, of course, there are various pelvic escape points that we all should understand. The obturator and the ischiatic escape points lie towards the anterior part of the pelvis. The pudendal escape point lies towards the center of the pelvis, whereas the gluteal escape points lie towards the posterior aspect of the pelvis. Now, there are different sources of reflux that can happen, and these sources have been divided into different zones. Zone 1 consists of the left renal vein. Zone 2 consists of the gonadal and the internal iliac veins with pelvic venous plexuses. Zone 3 of the pelvic origin extrapelvic veins, and Zone 4 involving the lower extremity deep and superficial veins. Now, we must understand that a reflux arising in Zone 1 can lead to symptoms in Zone 2 and also in Zone 3, and similarly, reflux arising in Zone 2 veins can lead to symptoms in Zone 3 and Zone 4. Now, different patterns of reflux have been seen. The most commonly identified veins which were refluxing was the left ovarian vein and the right internal iliac vein. The right ovarian vein was the least refluxive vein in the pelvic venous system, and a combined reflux was seen in more than 50% of the patient population studied. Once we know that there is a pelvic venous congestion or reflux or a disease that is happening, of course we need to evaluate these patients further. The first examination is always a transabdominal or a transvaginal duplex. Further evaluation can be either in the form of CT or MR, and even a dynamic conventional venography with or without the use of an intravascular ultrasound. Now, there have been various classification systems that have been used for the assessment and management of pelvic venous disorders, but the one that encompasses a complete anatomic and hemodynamic picture is the SVP classification that has been proposed by Mark Meisner's group, which consisted of various professionals from across the globe. Now the SVP stands for the symptoms, varices, and the pathophysiology, divided into four different sections, just like the SIAP classification. And similarly for the symptoms, it's the varices in different segments. And of course, the pathophysiology consists of the anatomy, the hemodynamics, and the etiology, the A, H, and E segment of the pathophysiology component. The anatomy, of course, looks at all the veins that have been studied along with the pelvic reflex points, which is mentioned as PELV. You can see that at the bottom of your slide. The hemodynamics, as we all know, in these veins can be either obstructive or refluxive, and the etiology can be either thrombotic, non-thrombotic, or even congenital, very rarely. How to use this classification? Well, first and foremost, all 5 domains and subdomains have to be documented individually. We must understand that the pathophysiology domain or the P domain includes the anatomy, hemodynamics, and the etiology. Now, let's say if there is a May-Thurner syndrome of the left lower extremity causing edema, it would be classified as an S0, V0 because there are no symptoms or varices related to the pelvis. It will be classified as pathophysiology as the left common iliac vein, the hemodynamics as obstructive, and the etiology as non-thrombotic. Now, along with this, also the SIAP classification is supposed to be used in its independent manner to do a complete assessment of what the pathology actually is like. And of course, there's a scoring sheet that has been given, which can be used very comfortably. Now, the treatment, of course, consists of embolization. Various forms of embolization materials and techniques have been used. Coils, of course, are the ones that have been used most commonly. There is a hybrid technique also that is used, which uses foam distally in the varicosities and coils proximally in the main trunk. A lot of investigators have used glue with or without foam, and very rarely even plugs have been used to occlude these vessels if the vessel is grossly dilated. Now, we should understand that ablation should start distally and proceed approximately both to stop reflux in the future and to reduce the risk of pulmonary embolism of any device that is left high in the vein. Of course, the outcomes. Literature has been divided as far as the success of symptom relief is concerned, and the success ranges from 60 to 100%. We must understand the difference between technical success and patient-related symptoms. And last but not the least, we must also understand that the cause of chronic pelvic pain can be both venous and non-venous, and both these pathologies can coexist at the same time. Thank you very much for your patient hearing, and I thank the organizers for having given me this opportunity to present my views on a very complex yet not looked at very frequently problem as far as venous pathology is concerned. Thank you very much for your time and attention.
Thank you, Adarsh. Now we move on to the next topic, which is happens to be an interesting topic, venous trauma, the battlefield experience, and Dr. Manvendu Jha, is he going to join us here or is he going to join us virtually? Virtual, okay. So let's move on to his talk as well.
Morning everybody. I will be discussing my small experience of venous trauma that we managed over a period of 4 years in an austere environment, basically in anti-insurgency ops. The period of my study ranged from January 2017 to September 2021. In above this, we included all patients with arterial and venous injuries. The brought-in patients were excluded from the study, and pro forma was noted in terms of age, sex, transfer time, the mode of injury was most of the time it was penetrating, and the treatment given complications and outcomes. The age of the patients were all young serving soldiers, ranged from 21 to 47 years. We had 46 arterial and 54 venous injuries. Most of them were combined. There were few isolated injuries. All cases were, the nature of injury was all ballistic in nature. All gunshot wounds or splinter injuries or mine blast injuries. This is one such injury which came. It was multiple splinter injuries, if you can see. They are not bullet wounds, there are multiple splinter injuries which came of the left lower limb. The majority of the involvement was the lower limb. We had 24 cases involving the lower limb veins. Majority was popliteal vein. We had 15 injuries, out of which 4 were isolated popliteal vein injuries and 11 were involving both artery and vein. Same for femoral, we had 2 isolated SFA V injuries and 4 combined with the SFA. The tibial veins, we had 3 cases. In the upper limb and all, internal jugular vein and SMV. In abdomen, we had renal veins. In the associated injuries, we had all sorts of things, including craniofacial trauma, thoracic and abdominal, gunshot wounds, orthopedic and nerve injuries. So overall, we had the lower limb vein involvement in 24 out of the whole 34 cases. You can see in this picture, this is the SFA which has been severed, and this is the SFB. In this case, we had done a intervention graft repair for the artery and a lateral venous repair for the vein. 8% of the limb injuries had come to us with effective tourniquet. Most of them were evacuated by the peripheral medical officers. The mean time of presentation was ranged from 1.5 to 19 hours. Obviously, there's a drastic difference depending upon the location of the patient, the climate, evacuation facility available, and time to evacuate the patient from the firing area. The timing of surgery ranged from 2 to 7.5 hours. This is the whole time of surgery, just not the vascular part. We had a limb salvage rate of almost 91.67% with an amputation rate of 8.3%. Only one patient who came to us within the 12 hours, we had an amputation. Rest of all, we had successful outcomes. All the bypasses were done using the saphenous vein. Fasciotomies were done in 18 patients. We had 18 cases of foot drop, out of which 15 had recovered within 6 months. In treatment modalities, we did primary repair of the veins in 9 cases. Most of them were lateral venorrhees or anterior wall suturing of the vein. These were basically mainly the SFB and the CFB. And in the 3 cases, we had jugular vein primary repair. 11 cases, out of which maximum were popliteal vein injuries, we did a interpolation vein graft. And we made it a point that we repair all the venous injuries in sync with the arterial injuries, not just ligation. But in the distal forearm veins and below knee veins, we had to do ligation in overall 14 cases. The complications, we lost 3 patients due to AKI with MODS and 1 to deperfusion injury. We had 3 amputations as already discussed. We had 15 cases of foot drop and 3 cases of wrist drop. The main problems faced were basically evacuation. Unless the patient was on roadhead, we had heli evacuation rule out, but majority of the patients could not be evacuated in time because of heavy shelling or weather or snowfall. So air evac became a problem. That's why the mean variable time of evacuation was there. In pre-hospital trauma care, cannot be given in a wholehearted manner at the site of encounter which is going on. Hypovolemic shock, recent to revascularize, always a bane for the vascular surgeon to do or not to do. Especially when the patient has multiple injuries, he is in important shock, and obviously heparinization is a big problem. Now we always, as everywhere time is done, we prefer life over limb and the role of damage control surgery, especially when multiple organ systems are involved. Role of primary amputation cannot be overlooked as a life-saving measure. Now, majority of our patients had penetrating injuries, so everyone came in variable degrees of shock. So we did not give any heparin in the trauma center or preoperatively because most of the patients were in resuscitation. In few cases, depending on case to case basis, we did give heparin, especially in popliteal artery injury repairs, but we gave only 1/3 of heparin dose just at the time of anastomosis. After we had taken arterial control and harvested the vein graft, we gave heparin. We ensured it that we always do the vein repair also in time. Obviously, there is a bleeding risk is there, but again, in heparination also you are to give or not to give. But as a vascular surgeon, you always tend, especially in limb injuries, we bend towards giving heparin, though in low doses, and we preferred infusion of unfractionated heparin over low molecular weight heparin. To conclude, mortality and morbidity due to triad trauma has decreased significantly. We have moved towards endovascular approach, especially in arterial cases, but not in venous ones. Autologous graft is always preferred. We encourage the medical officers in periphery to put a tourniquet before transferring the patient to us, but we never applied a tourniquet during our surgery part. And repair of vein was given equal importance as that of artery, especially in the lower limbs. Thank you.
Thank you, Manvendu. I understand that both Arvind and he are online, but we'll take questions in the end. Dr. Shekhar, we'd like to hear from you about iliac vein stenting. We know that you have been part of this journey, the past, present, and look forward to knowing what's in the future from you. Over to Shekhar.
Good morning, friends. Over the next couple of minutes, I'll be sharing my slides on the evolution of venous stenting. To start with, let us see what the steps for evolution were. It started with, and I think that is still evolving in our country, accepting the role of outflow obstruction as a pathophysiology for the symptoms that happen in the leg, especially non-healing venous wounds. The other evolution is accepting that it needs to be addressed with stents. And then there is an evolution of stents, which I'll speak about, and of course the role very briefly of IVUS. Dr. Robbie has already touched on that, so I won't dwell too much into the role of IVUS. Of course, I'll be talking about a little bit, one slide or so on what the future holds. Well, why there is so much talk about a narrowed venous a narrowed iliac vein segment? It all starts, if I can take you back to your early days where we used to study physics, when you look at the Poiseuille's law, you can clearly understand that the resistance to flow is inversely proportional to the radius to the fourth power. So in essence, therefore, a twofold increase in radius decreases the resistance by 16-fold, and as we all know, the basic essence of putting in stents is to reduce the venous hypertension. So this is the physics involved in putting in stents into the vein. And once we started, understanding the value of this, that is when, the whole process of venous stenting picked up throughout the world. The first reports of a successful deep venous stenting originated from Germany, Sweden, and the US in the early 1990s, but the mainstream attention increased rapidly in the early 2000s after the publication by the Stanford group of O'Sullivan and Dake, and of course the best known series by Neglin and Raju. To start with it, the first understanding was that arterial stents are different from venous stents. In the treatment of arterial stenosis, the goal is to restore peripheral perfusion without any dissection or extravasation. To avoid these complications, arterial revasculation is performed without actually being a strict perfectionist, in the sense that the goal is basically to just restore your distal circulation, and so a little bit of under correction still achieves an acceptable clinical result. On the other hand, as far as venous stenting goes, the whole goal is to eliminate peripheral venous hypertension, and even a minor residual venous stenosis can actually contribute to elevated peripheral venous pressures and residual symptoms. So this is where the whole evolution of venous stenting and the understanding played a role. And therefore, as I said, the critical stenosis threshold in the venous system is regarded by some as being much smaller than what is acceptable in the arterial system. The stressors in the venous system is also different, so the understanding of this itself, once we started understanding this, we evolved as in our role as clinicians putting in stents into the veins. The stressors in the vena cava, cavo-iliofemoral system is different. As you can see, the vein is exposed to repeated arterial pulsations. And with the changing position of our body, in ambulation, the geometry and the movement of the pelvis, the shape of the vein also changes. Additionally, there are other mechanical stressors, which I won't dwell into deeply, but you can see on the slide. So what is the ideal venous stent? With these requirements of venous application in mind, the ideal venous stent should ideally have a balance of radial force as well as flexibility. The flexibility is because it should conform to the shape of the vein, as and when the vein, as I said, with the movement of the body and the movements in the pelvis, it takes up a different shape, so it should conform to that. And so ideally, the vein dictates the shape of the stent, that the vein should dictate the shape of the stent rather than vice versa. The current stents for the arterial system are frequently quite rigid, And because of that rigidity, they conform, they are non-conforming to the shape of the vein. And so basically what it does is it straightens out the vein without allowing the vein to be in its original shape, dynamic shape that it is in. The ideal venous stent is also larger, and so as you can see that it should span most of the cases it should span the entire common and external iliac system. It should be precise without foreshortening. Unfortunately, that is a trade-off for increased radial force and flexibility. And most of our patients are much younger, so you need a venous stent that is durable and lasts for a considerable time. It is said that a venous stent, ideal venous stent, should last at least 50 years, if not more. So the first stent was the Boston Scientific wall stent, and as you can see, the results are pretty good, especially in the NIVLs, slightly inferior in the post-thrombotic disease, but they're pretty good. And especially in the healing of venous ulcers, which is probably one of the most common indications that we use them for. But it's not without, this is the picture of the venous stent, wall stent, but it's not without any shortcoming. The two shortcomings of the Boston venous stent, one is that if you study the body of the stent, if you study the anatomy of the stent, you realize that the body of the stent is strongest in the center, and the two ends are soft. And much more compressible. So if you want to do a precise, say in a May-Thurner syndrome, you want to precisely deploy it, you may land up, deploying the soft, compressible end of the wall stent at the exact site of compression, and that may lead to this kind of coning that you see in this picture. So to avoid that, what was recommended was that the wall stent should jut, and most of us, when we started several years back doing venous stenting, what was taught was that the venous stent should jut well into the IVC. Now, that was what the idea was, because we were using wall stents. And the downside of it was that one did not foresee that this adapted technique led to the contralateral iliofemoral DVT, and more cases as days went started being reported where we saw a successful venous stenting in one leg, and a couple of months or years later, patient presenting with due to the jailing of the opposite common iliac, presenting with DVT on the opposite side. So to overcome this, what was then suggested was the Z stent. And this was applied, and you can see the Z stent being rigid was applied, in a kind of a telescopic manner over the Boston wall stent, and the results are pretty good. In fact, there are good studies suggesting that the incidence of contralateral DVT were acceptable with this technique. We have a present generation of newer stents now. There are about 7 of them available in Europe. In India, we have only the red marked ones. They have been studied well, and at least 3 of them are available, and we use them, including the obliquus, which you can see here. They have all undergone good trials and successfully been studied. A little bit about IVUS. Of course, the IVUS is one more evolution tool in evolution which actually helped. But as Dr. Robbie suggested, initially we were all doing this kind of a balloon wasting test, quite a messy thing and not accurate. But then with the evolution and more access to IVUS in our country, and now quite a few centers I find are doing IVUS in venous stenting. You can see the positives and negatives of these. I won't go much into that, except that you can see a post-stenting, the IVUS actually gives you a good, wide, patent venous stent. The future, of course, and this is my last slide, is bioabsorbable scaffolds. We know they have been used quite extensively in cardiology and then been withdrawn due to various reasons. The advantage of having a bioabsorbable scaffold is it provides a vessel support, and potential anti-proliferative drug delivery can be added to this biodegradable scaffold. Theoretically, it's a good option. There can be less concern of jailing of the venous tributaries, including the contralateral iliac vein, and there could be a decreased risk of late stent fracture and late stent thrombosis, which was an issue with the biodegradable stents when they were used for the cardiac, in the cardiac scenario. Also, the scaffold could be less magnetic resonance and computed tomography imaging artifacts with the biodegradable stents. Due to the larger venous diameter, probably the issue of late stent thrombosis would be low, would be less. But this is all work in progress, and probably the future of venous stenting would be when we actually get this kind of technology for use in our clinical practice. Thank you.
Thank you, everyone. And I think we have come to the end of a very interesting session. And I think the take-home message is that anyone who is doing deep venous interventions, IVUS is a most important tool in your armamentarium. And as Robbie showed, a very interesting case. And it's very interesting to realize that these dynamic compression in various areas could be caused by various things. Like in that case, probably the caudate lobe of liver causes the compression of the IVC, which is a dynamic compression. And this can easily be missed on a CT venogram because normally when we carry out a CT venogram, we tell the patient to hold their breath. The moment the intrathoracic pressure increases, the IVC expands, and you miss these lesions. So if you don't have IVUS, then you will be totally missing these lesions. For all chronic non-healing venous ulcers, the patients who had undergone various interventions, CT venogram was the ideal investigation, I would say, a decade earlier. But now, if we have a patient who has a non-healing venous ulcer despite various interventions, I think rather than subjecting them to a CT venogram, we should straight away order for a diagnostic IVUS study, and in case we should counsel them that in case we see a lesion, then probably we're going to stent it as well. And
Yeah, thanks, Tarun. I think we have about 5 minutes probably just for some questions or comments. Just trying to keep in time with the session.
One question to Dr. Shekhar. Hi, Adarsh. Our experience in Vellore is the post-thrombotic legs, we are not having a very good results on the long term with venous stenting. For some reason, the Indian setup with the population, the follow-up is not very great. So we're kind of now very, very selective about venous stenting in post-thrombotic legs which we recanalize unless it's very, very necessary. We don't go in and put in the stent. Whereas in the late turners, we are very happy to do the stents because the longevity of the stents is much, much better. And I'm not sure if others have the same experience.
Shekhar, Robbie, anybody wants to take that on? That in post-thrombotic limbs, the experience with stenting is not great.
I think that I think that goes with the literature. If you see the literature, the best results are with the NIVLs, the Methana type. Unfortunately, the load of post-thrombotic legs in India is huge, and the bulk of the patients who we do stenting for are who have had venous ulcers for years, and they are just searching for solutions, and this is one solution. Even if you get a 60% or 65% chance that the venous ulcer heals, I think the patient accepts it. But yes, it goes with the data worldwide also that venous stents are better for non-thrombotic rather than thrombotic.
Thanks, Shekhar.
So I would actually agree with Deepak. I mean, we were very aggressive treaters of post-thrombotic syndrome with stents, and we reported our data for venous ulcer healing. And venous ulcer healing is about 60%, but it does not say sustained. Stent patency in PTS is our own experience. It is not 88%. That range of 66 to 88 is, I think, I'm not very sure where that data comes from because that 88 is not what we see in practice. And I would agree with Deepak that in post-thrombotic syndrome, I have become much more conservative in deploying a stent. I will aggressively venoplasty, but I'm more conservative on putting in a stent. It doesn't stay open very often.
We have others. Do you want to ask us something, or do you want to comment briefly?
Arvind, and my question was that was with regards to the timing of stenting in the upper limb post lysis and post resection. And then how do you keep them open for a long period of time? Because the outflow in the upper limb veins is not as much with regards to the cardiac output as it is for the lower limbs. So how do you go about with maintaining patency in these stents?
I think the question is for Arvind while he comes on.
Yes, sir.
Yeah.
Okay.
Yeah, like I said, can you hear me?
Yeah, can.
Yeah, sorry. Like I said, I'm not a big proponent of placing stents for upper extremity DVT, the page is shorter. The data seems to suggest that just with lysis and first rib resection, regardless of how the vein looks after the procedure on venography, we get good results. We get symptom resolution. So the placement of stents is actually not essential. What we do, we use the angiojet for lysis. Then within 2 weeks, we bring them back and take the first rib out. At the same time, after we've done the first rib, we do a venogram during that same anesthetic, and then we balloon that vein up to about 12 millimeters, and that usually gives us some good flow through the vein. It doesn't look pristine, it doesn't look perfect, but we don't generally place a stent. The only time we would consider placement of stent is even after all that, if it looks like there is no flow, then we may consider placement of a stent. If we do place a stent, then we'd be obviously placing them on dual antiplatelet therapy and anticoagulation. So dual antiplatelets for 6 weeks, and then anticoagulation and aspirin alone for the full period of 6 months after that. We usually also at that time would put a double tubing grip on the arm and put a calf compressor. You can put a sort of a small calf compressor on the arm, and then we connect it to a sequential compression type of thing for the first 24 hours to just kind of keep that flow. As you mentioned, the flow is sluggish and it's not ideal for keeping a stent open. But like I said, we don't routinely place stents. In fact, in the last handful of cases that I've been involved in, we have not placed a stent.
Thanks, Arvind. We are short of time, so just one last question from Ilya Kumar.
Dr. Manvanduja, impressive series for venous repair. Just a comment. The role of heparinization in these trauma cases, which I like to add is, it improves the patency of your repair and also prevents progression of the thrombosis, and so it keeps the collaterals open. So have a more likely chance of limb survival, one. Second is, how long do you anticoagulate these patients? Since the venous repair, we know, goes down, but as long as it functions, it keeps the arterial, it improves the patency of the arterial repair. Thank you. And can one more small question? No, thank you.
Adarsh, I think the question is for you. I'm not sure. Did you hear us?
I think the question was for Manvendu Jha, but I can answer that question.
That's a trauma
So
one.
I fully agree with Ilya Kumar.
Yeah, that's for trauma. Yeah, Manvendu Jha. Is Manvendu online? Okay. The other thing is, I think we are getting questions on chat on the group. So kindly, speakers, could you please look and respond on that? Dr. Shoaib, I'm really sorry. We need to run on time. So we'll keep chatting on the group. Thank you very much, everybody, and we'll go on to the next session.